right. Well, welcome everybody to our second of our weekly webinars for Brain Tumor Awareness Month. I'm Chris Farrell. I'm going to share my screen here. All right. Hopefully everybody can see this. So it's my distinct pleasure to welcome everyone to this webinar. I think it will be another great session. We got off to a great start last week. And all of this is done to celebrate Brain Tumor Awareness Month. As many of you may be aware, we have Go Gray in May to celebrate brain tumor awareness. And on behalf of our Department of Neurologic Surgery and the Brain Tumor Division in our Multidisciplinary Brain Tumor Center here at Jefferson, we want to thank everyone for attending tonight. Brain tumor awareness is intended to recognize the vast number of patients who are afflicted with brain tumors, their families, their friends, everyone who supports them, as well as the medical personnel who dedicate their lives to fight against brain tumors. This month we've got a series of things that we're doing. I think, first is a great celebration for our brain tumor support group. This is something that we run throughout the year, and we'll have a special session on Thursday, May 14th in our Honeck building. Kristen Slafer, who's done a wonderful job leading this, will start things off at 5:45 with a dinner to follow and our annual Cassandra Murphy Award presentation. We'll have a series of weekly brain tumor webinars that I'll discuss in a second. We'll also have a series of weekly Facebook posts and other social media emphasizing, the team members and our mission. We also have this great giveaway that Kristen put together to celebrate Go Gray in May, these blankets and non-toxic lip balm. So I said this is the second of our webinars. Today, I hope everyone got the schedule switch. One of our speakers wasn't available, and we had to shift things over. So today we're going to talk about what's new in brain and spine metastases. Next week we'll follow with benign brain tumors, and finally the questions you've been wanting to ask. We have a great panel today to discuss brain and spine metastases. We have two of our newest faculty at Jefferson who are just incredible. Stephanie Robert from our brain tumor division, who we recently recruited from Sloan Kettering. We'll talk about brain metastases. And Dr. Kevin Hines, who trained with us and stayed on after a spine fellowship to discuss spine metastases. They will each give their presentation, and then we'll have some time at the end for questions. So I know this will be a great session, and thanks everyone for joining. I'll turn it over to Kevin, who I think is starting things off.
Thank you. Thanks for the introduction. Thanks to everyone for joining. I'm Kevin Hines. I'm one of the spine surgeons here. I specialize in both spinal oncology, spinal tumors, as well as pain syndromes associated with cancer. So there's a lot of interesting and exciting things that are going on. And I think that a lot of the treatments and things that we can offer for patients are not well known about and need a little more awareness. So, obviously we would love to see anyone who has questions or has any concerns, but spine, why are we talking about spine tumors or spine metastasis in brain tumor month? Well, especially with metastatic disease, it is extremely prevalent. Patients who have metastatic solid tumors, 15 to 20% end up with basically spinal metastatic disease, whether that's in the spinal column, the bones, or in the epidural space, the space around the nerves and around the spinal cord. This can create issues with pain, with mobility, with nerve function or spinal cord function, and can be very dangerous if not treated or not recognized. So there's a lot of great ways and great screening to do that, and a lot of options for patients who are receiving multimodality treatment, but still struggling with certain kind of functionality, pain, and quality of life issues. I do emphasize that everything we do with spinal metastasis and spinal oncology is a multidisciplinary field, and we can't do it alone. And we work very closely with medical oncology, radiation oncology, cranial surgeons. So we really do work together, given the high incidence of these issues, especially in our metastatic tumor population. When do we do surgery, or why would we talk about surgery? Is really, one, we want to help control the disease at that level. We want to help with your symptoms, with their quality of life. If there's a certain type of pain, are we able to help with it? Can we help you enjoy your quality of life? And then protection of function long term, protection of the nerves, spinal cord, the spinal column. These are all things that we are at the forefront of our discussion. We have a lot of tools that we can use to combat spinal disease. And they all kind of come in varying invasiveness, minimally invasive, more traditional open surgery. There's also techniques that can help with certain types of pain, and a lot of things that we've been developing and working and getting more and more evidence that can be helpful. There are radiation. This is a non-invasive way that we can help control disease in the spine with very high control rates. You can stop the progression. It has a great effect on pain, cancer pain from these mets in the spine. It can help with some of this epidural extension to help protect the nerves. And you also, this stereotactic radiosurgery, you can also use it to salvage some other types of radiosurgery or radiation to allow for retreatment. So these are great options. We've found that this targeted stereotactic radiosurgery that we work with our radiation oncology colleagues is actually better from a pain standpoint overall, and helps with pain reduction and great control of these tumors. Basically, instead of, you can see on the left there that you can use multiple fields to better shape this radiation and better deliver it to a more precise area at a higher dose, to allow to, one, protect things like the spinal cord, and two, deliver a higher dose to what we think is concerning for tumor for better disease control. Once again, this is nice because it doesn't require a surgery, and this can be a great way to help control disease in a non-invasive way and protect your quality of life. When the spine is affected by tumors, you can have issues with the bone being softened and cause what's called compression fractures or pathologic fractures. These can be very painful because they can be partially unstable, creating pain whenever patients move. When this happens, we have the ability to actually in a minimally invasive fashion, enter the bone, inflate a balloon to reduce or bring up the height of the bone again to where it was, and place cement in there to help solidify and stabilize that bone. That's a procedure. It's a same-day procedure. It's done just with needle entry sites. There's no true incision, and the patients get to go home the same day. So, not everything that is surgical or spinal involved has to, involve traditional open surgery with some of the, concerns, rightfully so, that patients may have about recovery and the effect. And ultimately, this is a pain procedure to help with stability. It doesn't necessarily help with local control, although some people are investigating if the cement itself has any effect. But in addition to kyphoplasty or vertebroplasty, not just the cement, before you do that, you can actually place a radiofrequency probe into the bone and burn it, essentially, and burn the tumor. And this ablation is also shown to help with cancer pain and pain in tumors in the bone. So this is a great option to, especially when it's isolated to just the bones, to make a minimally invasive approach that can have a very short term and rapid effect. Normally helps patients' pains on the order of days to weeks, whereas radiation may take a little longer, weeks to months. So it's a good, fast-acting solution with a great kind of more, complication, low risk of complication, good side effect profile, and patients tend to recover well. So just an example, right? That's just a small needle that can go in, and then in the middle panel, you can see cement that is actually placed into the vertebral bodies to protect that fracture from collapsing further. So once again, a great option in a minimally invasive kind of setting. Then we have something called separation surgery, which is used in concordance or concurrently with radiation and other systemic treatments. The idea is that we're trying to protect the spinal cord and nerves, and we make expose just enough to clean the tumor and push it away from the vital structures. And then we can stabilize the spine and let radiation do the rest because it has such an excellent control rate there. So that, one, can stabilize the spine, protect it from inappropriate or dangerous movements or instability, and then also create space for the nerves and the spinal cord so that effective radiation can be given to the tumor, but also sparing important structures such as your nerves and spinal cord. The idea is that you can drill a little bit of bone to make space for the nerves, clean off tumor that you can, and then allow stabilization of that spine. In addition, there are people who, the bone has been so affected by tumor that you can have issues with the spine itself being grossly unstable that it could be dangerous to the spinal cord, or it's so unstable that putting cement in that minimally invasive fashion is unable to secure the spine in a proper way that would give pain relief. So there are other options. There are ways that we can measure this and predict this, and there are minimally invasive ways, percutaneous access to place instrumentation to protect against fracture, to protect against instability, and allow the bones to fuse and join and heal over time while still not having to pause for very long. Once again, the idea is that with percutaneous and minimally invasive options, we're able to still instrument the spine, still help with these really unstable and painful lesions, but then also try to get patients back on treatment, because the overarching theme is in metastatic disease. We have to be sensitive to the other health changes and other health conditions going on that need treatment as well. So, and then there are things that, it can be multi-stage, bigger open surgeries. We have new tools available to us that make these safer. We're getting better and better. We have the ability to use image guidance. We have kind of expandable prostheses or cages that can help replace bone that's resected and create a really strong column of bone behind it. So that even these traditional open surgeries that have great efficacy are getting safer and more effective and more minimally invasive with different approaches, from percutaneous, lateral access. These are all things that have been developed in last 5 to 10 years that are getting better and better with the tools that we have available. The idea being, as you could see, that having a tumor that's pushing into the spinal cord, you can see on the MRI here and here that there'd be concern for spinal cord compression, not necessarily recognized on a CT alone, but then we're able to instrument and place a cage, as you call a prosthesis, to help support where that bad bone was, and we clean it away from the spinal cord. And this patient can go from being unable to walk to being, was actually able to walk within a few days. So we have things like that. We're developing new tools all the time. It's now becoming more common to use robotic assistants to help us place instrumentation if we need to. One, narrows the exposure that's needed, the visibility that's needed, and it also improves our accuracy, especially when there's question of bone being strong. We want to be able to secure that bone and allow for adequate purchase, accurate placement, but also not have to open up and see more of the anatomy when we know patients are at risk for not healing when they're getting other treatments. Other things that have come about is that we have access to something called carbon fiber screws. The instrumentation that we're using is more friendly with these other treatments, so it actually creates less MRI and CT artifact, which means that it's easier for our radiation oncology colleagues to visualize the anatomy, deliver higher doses of radiation, and monitor more safely and easily for any recurrence of tumor. These are all great tools that are coming about. In addition to these, spinal metastasis, we also, in the same conversation, always discuss things like pain itself. Cancer is unfortunately comorbid with many chronic pains. It can come from within the pain, or within the spine, or from outside of the spine. When this happens, it can leave a very huge impact on a patient's quality of life. And not every patient's cancer is amenable to one of the many options that we already did discuss. So when that happens, though, we do have other options for patients who are in pain, and we really want to, minimize pain, improve quality of life, and do things to help them when able. One of them is something called intrathecal drug delivery. This can be for patients with spinal metastasis or even elsewhere. Rather than, when patients are taking pain medications and they start to have side effects, or they can't get the dosages high enough to give them good relief, this is a procedure where we can actually place a catheter under the skin into the spinal fluid and a pump under the skin that delivers continuous medication at concentrated doses near the nerves themselves, and has much higher potency, can improve quality of life, engagement. Some studies suggest that with pain relief, patients can engage more, sustain more treatment, and do better long term. So it's doesn't undo and kind of everything that's going on, but it can be something that can make a huge difference in patients' lives. It just requires a couple small incisions to get the catheter in, and then the placement of the medication pump. There's other things too where we can disrupt pain fibers in the spinal cord itself. This can be for people with very, very severe pain that's almost in their abdomen or their pelvis related to cancer. And then even people who have limb pain as well, there are options where we can disrupt pain fibers with a needle and an ablation of a pain tract itself. So, these are all, this all goes to say that there are options. These are very challenging diseases. Patients who can have metastatic disease can have pain, issues with functionality. There's the aspect of trying to control the tumor and the cancer as well, and even asymptomatic lesions that we need to understand what can we do to control them early, have a plan for them, and prevent them from becoming a bigger problem down the line. We encourage our patients with spinal metastases to have regular follow-up and have a full team involved in looking at these lesions. That way we can understand, should we radiate something early? Is there something that we should just monitor? Is there anything else that can be done to help, maximize the treatment for these lesions and prevent them from becoming a problem if possible? People can find these things on their PET scans, their CT. It can be from spinal pain itself. It can be hard to differentiate from arthritic pain, aging pain. But if there's a new or unusual pain or something that's been getting worse, it's worth discussing with your team. And then finally, things like weakness, numbness, neurological symptoms in your arms or legs are all things that would trigger us to get advanced imaging. We work with the medical oncologist, the radiation oncologist, neurosurgeons, both brain and spine, pain management, palliative care. These are all resources that we use to work together and maximize what we can to help. And everything is, we try to look at it from the 10,000 foot view, which is how can we help? What can we do that's going to help you and protect you? And sometimes we don't always have a great solution. They can be very challenging, but there are a lot of options and a lot of ways that we can discuss trying to help. And that's all I got.
Thanks, Dr. Hines. I will get started, and I think we're going to leave questions until the end. And we can also put them in the chat if anyone has questions that they want to hold on to and not forget. Can you see my slides?
Yes.
Excellent. So I'm Stephanie Robert, and to kind of go from spine to brain, which is what I focus on mostly here, I'm going to follow up what Dr. Hines was talking about from a spine standpoint and talk about what is new and how treatments have changed from a metastatic brain tumor perspective, and why patients now have many more options than they did just a few years ago in this disease. What I hope that you take away is that although brain metastases really are one of the most challenging complications that we deal with for cancer patients, it's also an area where treatment has dramatically changed. Even 10, 20 years ago, patients were treated pretty uniformly if there was a brain metastasis that was found. However, today care is much more individualized. We consider the number, size, location of these metastatic lesions, the type of cancer a patient might have, their molecular profile, symptoms, other treatments, and what systemic therapies they're on, because those have also improved significantly, which has changed really how we manage this disease. And the goal really is not only to control the disease, but really to preserve neurologic function, cognition, independence, and quality of life. And so brain metastases really are becoming increasingly treated as part of a long-term coordinated cancer care plan that is individualized for each patient, depending on the type of disease that they have. And it's really less of a single best treatment as it used to be just a few years ago, but really how to choose the right treatment for the right patient at the right time. And so what are brain metastases? We hear about these, but sometimes it's difficult to actually understand what that means. And really what it is that brain metastases are tumors that start elsewhere in the body, so lung, breast, melanoma in the skin, kidney, various other areas. And they, through the blood vessels, as you can see here, they spread from the primary origin through the blood, and they get into the brain, and they're able to set up shop and grow in the brain. These are very different than another type of tumor that I treat, which are primary tumors, things like glioblastoma or gliomas that actually arise from the brain and grow in the brain. These arise elsewhere and figure out a way to change what they're doing to live and adapt to the environment of the brain. And they actually end up behaving more like the original cancer that they came from rather than a primary brain cancer. And so treatment in this case requires coordination between neurosurgery, radiation oncology, neuro-oncology, and our medical oncology team who are typically treating the rest of the disease. We're seeing more and more brain metastases. And in a large part, that's actually because cancer care has improved and the overall prognosis and outcomes for patients who have lung cancer, kidney cancer, a variety of other cancers really has significantly improved over the last decade or so. And this is because of things like targeted therapies that are targeting mutations within the specific systemic disease that patients have. Immunotherapy that's ramping up the immune system so that the immune system learns that there's a tumor and it's no longer masked. The tumor has a way of masking itself, and we're uncovering that with things like immunotherapy. And we also have better imaging and better surveillance, and that allows us to actually monitor and know when these lesions pop up sooner so that we can treat them faster. And overall, just improved nutrition and overall disease control of the systemic processes that's going on. But then the paradox is, as these patients are living longer, the brain becomes a very important site of cancer control. And so really the big shift that we've been seeing is that we've moved from kind of a one size fits all, where a patient with a brain tumor gets surgery or radiation, really to more personalized care, understanding what disease the patient has and what the best treatment option is for that specific patient. And so the old model really was, if there's more than one metastatic disease in the brain, the patient typically got whole brain radiation, which is radiation to the entire brain. And, it was often treated more as a palliative kind of end of life sort of treatment. But really, our new model, the new guidelines are emphasizing multidisciplinary decision making, looking at things like the number of brain metastases, where they are, how large they are, what symptoms patients are having, and what systemic therapies are available and how that affects the treatment that they might be able to undergo, what other treatments the patient's been on, and really overall, what are the patient's goals and health, and are they able to undergo specific types of treatments. And while symptomatic brain metastases generally do still require some kind of local therapy, meaning surgery or radiation, we're actually starting to lean towards asymptomatic and small lesions may actually be able to start with just CNS active systemic treatment with very close monitoring. And so we're seeing more and more of this ability to treat patients and see if their brain disease responds. Because of these advancements and the fact that patients who have metastatic lesions are living longer and there's more advanced systemic therapy, there really is a huge team involved. And that's something that here at Jefferson, we are well positioned to offer, is that, really the most important advancement in this field really isn't just about a drug or a device, it's how our teams develop and communicate. And really a team treating a patient with a brain metastasis involves neurosurgery, radiation oncology, medical oncology, neuro-oncology, neuroradiology, neuropathology, our nursing and care coordination, palliative medicine. So there's a lot that goes to it. And so it's very important that all these teams communicate and understand what the goals of the patient are and the goals of the treatment are. So just to go through the kind of main treatment options, the main and most relied upon treatment option really still is stereotactic radiosurgery or radiation to the brain. And what does this look like? It can be delivered through different technical ways, and things you may have heard of is things like gamma knife or LINAC or linear accelerator or cyberknife. These are just ways of delivering very high focused radiation. We call it radiosurgery. It's not actual surgery, but it's very focused radiation to a lesion in the brain while trying to spare the rest of the brain from being exposed to the radiation that we're giving to protect it. And it used to be that patients that had more than one brain metastasis that we couldn't resect underwent what's called whole brain radiation. And the challenge with whole brain radiation is that the entire brain gets radiated, which is obviously not ideal if there's not a lesion there that you're trying to take care of. And so what we're learning and what we've been learning over the last decade or so is that we can actually treat more than one lesion with radiation. We can actually treat many lesions now with this focused type of radiation, and patients do really well with it. And now not only do we go by number, we actually go by total tumor volume, location, patient's condition, and how they're doing, which actually allows us to apply this to more than just saying, if you have 5 lesions, you get radiosurgery. If not, you have to have whole brain. So we have more flexibility as we understand how this technology really affects the brain and affects patients. And so this is just an example of what the difference between whole brain radiation versus traditional radiation versus something like stereotactic radiation, with the red being where the highest doses are, and then the green and yellow being other radiations, smaller doses, but still radiation the brain's getting. As you can see here, whole brain radiation, the entire brain receives some meaningful dose of radiation, whereas stereotactic radiosurgery, the lesion that we're trying to treat receives the dose, but the area and the area around it, but most of the brain is actually well preserved. And why this matters really is because whole brain radiation, while very important in certain situations and very necessary and helpful, especially in cases where there's many, many lesions where you can't treat them all effectively, things like leptomeningeal disease, where the tumor gets into the CSF, the cerebral spinal fluid, and the outer parts of the brain and the spine, or where there's widespread cranial involvement, bone, different areas of the cranial space, that really isn't practical to treat in a more spot, with more spot treatment. But the side effects are things like memory issues, processing speed, worsening fatigue, quality of life issues, and long-term cognition. And this is becoming more important as patients with systemic cancer are living longer. These are the things that we really have to start thinking about, because no longer do cancer patients live a few months. Patients often live many years. And so we have to really consider this becoming more of a chronic disease and treat patients in a way that maintain quality of life and their cognitive function. What is new, even within whole brain radiation, is that more modern approaches actually are trying to reduce cognitive effects for those who actually need to undergo whole brain radiation, which things like hippocampal avoidance. The hippocampus is where a lot of the memories are formed in the brain. And so if we can avoid radiating that, then we can sometimes improve things like short-term memory that often get affected with whole brain radiation, mantine to help improve memory and cognition, and then selective use of it, try not to use it when we don't have to, try to take advantage of radiosurgery, which is more selective and a little gentler when we're able to. Second treatment option is, of course, surgery, and so that's where we come in. And surgery is still very important. It's still very, very much indicated for many patients, but it's no longer about just removing a tumor that's causing some issue. It does help with removing mass effect and large lesions that patients are weak from, or having speech difficulties, or significant pressure on the brain that needs to be removed. That is typically the primary indication still for surgery. But it can do things like provide a diagnosis if we don't understand what it is. Some patients have more than one cancer. Some patients have no evidence of a systemic cancer. Melanoma can be difficult to diagnose without going to the lesion and actually getting the tissue. We can update a molecular diagnosis. We know that tumors that get to the brain sometimes change what they look like a little bit. They change expression of certain molecules that they express, and sometimes those become targetable. So we might have a better chance of targeting the brain lesion if we know what it's made of. And to help patients get back to systemic cancer treatments faster, to take out the lesion that's causing the problem so that they continue undergoing their systemic treatment, which really is the main goal from our standpoint, is to get the patients back on their systemic treatment. Lesions that don't respond as expected, again, that allows us to get a diagnosis and to take care of the lesion. But it really is part of a combined strategy where we discuss Do we need a tissue diagnosis? Can we do radiosurgery before we take out the lesion or after we take out the lesion? And there's different indications and reasons why we would do one or the other. And how does this fit with the systemic therapy? Do we need to change systemic therapy? Is that going to help us with treatment? Do we maybe hold off on surgery and see how the lesion responds to whatever medication the patient's on? Surgery is also not as big anymore all the time. Sometimes it is. Sometimes we still have to remove a piece of the bone and actually physically resect the lesion. But we are increasingly using more modern techniques, image guidance. We have advanced MRI technology that we can better look at the lesion before we just make decisions whether we need a big open surgery or a more minimally invasive approach. We can do functional mapping with the MRIs that we have. We can do intra-op navigation, awake navigation. We have all these tools in our toolbox. And then, of course, minimally invasive approaches, which are becoming more commonly used. More technology is being developed, things like stereotactic, or as we call them, needle biopsy, to take a piece through a small incision, or things like laser interstitial thermal therapy, which is kind of diagrammed here, where, and we'll talk about it a little bit more, but where it's a much smaller incision where we can treat the tumor through a tiny incision. And this is important too when patients have to be on systemic therapy that may not agree with having a large surgical incision. And so we have some ability to optimize and really personalize treatment based on a number of factors now. And then things like what we talked about, whether we radiate before or after surgery. There's different reasons we would do that and choose one of those over the other. And then LIT, which is this laser option that that I mentioned. And this is this is something that's becoming more popular and has been used in this field for the past probably around 10 years and is becoming more popular as we're learning more about how this treats these lesions. But what this is a minimally invasive technique, and this is kind of illustrating that, where you make a very small incision through the skull and you place, using this machine, a laser into the lesion using stereotactic navigation. And under MRI guidance, you can actually heat the lesion. And we know that proteins in the brain or in a cancer, when heated to a certain temperature, will die. And so it effectively kills the cancer cells. And we watch it on the MRI as the lesion grows and covers the cancer, the tumor. And we know that that is very effective in treating many lesions in the brain. And we specifically use it for things that are deep and eloquent areas, speech, areas that control your motor function, areas that we wouldn't necessarily want to do in an open surgery because of what we would hurt either trying to get there or trying to remove it. Things like lesions, like metastatic lesions that were radiated but start to regrow, are often well treated with this technology rather than giving them more radiation, which can cause issues. And patients who really can't undergo surgery. I had a patient who was on a very specific regimen of chemotherapy agents that did not allow for good wound healing, and her oncologist was a little concerned about having her off of it for treatment for 2 to 3 weeks, which is what I would normally do. So we actually did this procedure for a recurrent lesion. She was back on her systemic therapy in a couple of days, and she did great with it. So these are the types of ways that we can be creative, depending on the situation and depending on what is needed for each specific patient. And the other nice thing about this laser technology is that before we actually place the laser, we can place a biopsy probe, which is a very similar needle that you can place into the brain, and we can take tissue. So we actually get a diagnosis, we can update molecular profiling, understand what the tumor looks like, make sure we understand whether it is tumor or something else, and then we can also treat it under the same, during the same surgery, through the same incision. And it gives us a lot of options in this situation. What I've alluded to a few times is that after a treatment, after a tumor is radiated, whether it be a primary tumor or a metastatic tumor, so glioma or a metastatic brain tumor, they often get radiated, and they get radiated whether or not we operated on them. They can develop something called treatment effect or radiation necrosis. And it's something that we're studying but don't fully understand. We think it's some immune-driven process. And what happens is that we get, screening MRIs over time after treatment, and we see these lesions start to grow. And it's hard to understand often whether it's the tumor coming back, whether it's this treatment effect or radiation necrosis, or it's some mixture of both. And our diagnostic tools that we have, like MRI, we have this special perfusion MRI that we can look at, PET scans, these sort of things. They're not great at actually predicting or diagnosing whether a lesion is tumor or treatment effect. And it's really important because, as you can imagine, it really determines what the next step of treatment is going to be. You can re-irradiate tumor. If it's not, it's very dangerous to re-irradiate treatment effect because it can make it significantly worse. And treatment effect can grow similar to tumor, even though it's not tumor. So it also needs to be treated. And this is where something like this laser therapy can be beneficial, because we can go in and biopsy, understand whether it's treatment effect or recurrent tumor, and then we can treat either one of them or treat it relatively well with this laser technology. And then, in addition to the more invasive treatment options, I didn't go into detail about things like brachytherapy, where we can put radiation tiles in the brain. That's something that's coming up. There's a few other things coming down the pipeline that are becoming more used. I just wanted to focus on the most common things that are currently, out there and being used, but we can definitely talk about some of the more nuanced ones as well. But the final treatment really is systemic therapy. And to be quite honest, even 10, 15 years ago, it was hard to imagine that we would be talking about systemic therapy being so useful in the brain, because the brain has this thing called the blood-brain barrier, where it's a very privileged site where the things that are floating around the blood don't always go to the brain, because the brain's very sensitive and it can damage the brain. So there's this very tight barrier that prevents a lot of things that would otherwise go to the rest of the body from getting into the brain. And so for many, many years, we thought that barrier was always going to be a reason that the drugs that we give for systemic cancer weren't going to work in brain cancers. It's still an issue. However, we're getting better at targeting it and targeting the brain. And so some of the more modern drugs really are becoming meaningful, starting to have meaningful brain activity. And so it's changing the conversation about how aggressive we need to be up front, especially for smaller asymptomatic lesions. So there is some opportunity with some of the newer targeted therapies, immunotherapies, these new things called antibody drug conjugates, where they actually conjugate a drug to an antibody that targets the tumor. These things are all being developed, and we're seeing more and more CNS or central nervous system penetration of these drugs. And so there's some patients, with discussion with their medical oncologist and with all of our teams, that we can actually watch if the lesions are small and it's safe enough to watch, and see if their disease will actually respond before treating them either with radiation or surgery. And so it really depends on the tumor type, the profile of the tumor, what targetable mutations it has. So there's a lot to go into it. We don't take that lightly when we don't treat the lesion that we see directly with either radiation or surgery that we know works. But these are some things that are also being explored in clinical trials. Some clinical trials are looking at radiating some of the larger lesions, leaving some of the lesions that are smaller and can be watched. And so there's some creative ideas in this space that are really looking at how we might be able to selectively treat different lesions in the brains in different ways. So even more so than just personalized care per patient, it's really personalized care per lesion almost at some point. And so what does this mean for you all, for the patients? It means that it's no longer a simple question of radiation or surgery if there's something that is found in the brain in metastatic patients. We ask many questions. What type of cancer? Is there a mutation? Do we need a brain biopsy either for diagnosis or to determine if there's a new targetable mutation that we have a drug? And then can we watch and wait? Is the patient symptomatic? Is there brain swelling or mass effect? If there is, it needs to come out most of the time. What does the disease look like outside of the brain? Is the systemic therapy working? Have they been started on systemic therapy? Is it safe to watch this lesion? Is it at a size and in a location that could tolerate a little bit of growth while we see if the systemic therapy works before we radiate or operate on it? Would surgery help? We know that if these lesions are in certain areas of the brain, we know that actually removing them helps improve symptoms faster. It removes the edema faster. And so if patients are having significant symptoms, sometimes that pushes us to surgery when if they weren't having symptoms, we wouldn't necessarily need to do surgery, and it helps them recover and get into physical therapy and get back on their systemic therapy better. And can we do something more minimally invasive that would allow us to both diagnose and treat the lesion? Or do we need to do the normal open surgery and remove the lesion and get the tissue and the diagnosis? And what does that look like in the setting of the patient's disease and the overall goals of care? And so these are a lot of the conversations that I frequently have with my medical oncology colleagues, usually in the background, but these are constantly going on. And what's coming down the pipeline? What's out there? There's a lot. I will be honest. A lot of the clinical trials and research in this space really are focused on the systemic disease, but people are becoming more and more active looking at brain metastases, and it's something I'm personally very interested in our lab looking at. And the areas are things like new and better targeting CNS active therapies, these drugs that can get into the brain and target these lesions better. Combinations of immunotherapies that may be more effective at treating these systemic disease so that they don't ever go to the brain, which would obviously be ideal. Timing of radiation and systemic therapies like immunotherapy is there a timing that's better because the immunotherapy ramps up the immune system and so does radiation? Is there a way that we can more synergistically treat patients? Better imaging to understand these changes that we see after radiation, if they're necrosis or treatment changes, is there a way to diagnose that with either imaging or things like blood and cerebral spinal fluid? Are there markers that tell us what the tumor is, give us a more molecular diagnosis, understand that this is treatment changes or recurrent tumor? Tumor sequencing is very popular and common now, and we're trying to use that and take advantage of what's being done so that we can understand more about the disease and how it gets to the brain and how it recurs and how we could better treat it. Better drug delivery strategies. There's focused ultrasound where we think opens that blood-brain barrier up and allows treatment to get there better. Things like going through the arteries and giving treatment. So there's a lot of research looking at that. And then one of the major advancements really would be better understanding the brain immune environment, because we know that immunotherapies have revolutionized the cancer world and the way that we're able to treat patients. And if we can better understand the unique immune environment of the brain, I think we're going to have a better chance of understanding why these treatments aren't working as well as they are in the systemic disease, and maybe how we can make that change to where they work even more effectively in the brain. And so the goal really is to combine all of our knowledge and understand the disease process, and really to turn cancer into a chronic condition that we're managing rather than something that is still detrimental to many patients. And so just in conclusion, I hope what I emphasized is that there's a lot of options, and it's no longer a one size fits all, and it's dramatically changed even 10, 20 years ago. We have more precise radiation, safer and more tailored surgical strategies, more minimally invasive options, better systemic therapies with more brain activity, and a much stronger emphasis on this being a multidisciplinary decision-making process across many teams involved in each patient's care. And I think it's always worth asking, what are the options, and how does my specific disease fit into this very large network and all of these options that are available? And I think it's important to recognize that, of course, extending survivorship, extending life is the goal, but really the ultimate goal of all of this is quality of life, preserving independence, cognition, reducing steroid burden, preventing seizures, and maintaining the ability for patients to be on their systemic therapy. Because at the end of the day, our job is to get the brain and the spine disease under control so that the systemic disease can be treated and patients can be treated by their medical oncologist and continue with what they need to be on. And then, of course, things like minimizing time in the hospital and the patient's goals, which can't be understated, about what each patient and family wants and how we can extend meaningful quality of life for those that we care for. So thank you all. I appreciate the time and for you guys spending your Wednesday evening with us. And I think we can probably open it up to questions for the last 10 minutes or so.
As a reminder, the questions can be submitted through either the chat feature or the Q&A button at the top of your display. Looks like we have a few people typing right now. Thank you very much. First question is, how does cancer get to the brain?
That's a good question. I wish we knew. Um, it's something that we are very much studying. The broad strokes are it gets out of the tumor. So say you have a lung cancer and the lung is made up of tissue and a basically a capsule. And because cancer are malignant cells, so they're cells of the body that have somehow developed mutations to where they continue to grow and they can recruit blood vessels and they can recruit things that allow them to survive and grow. And because they can do that, they are able to bust through the normal tissue barriers and they're able to get into the bloodstream. And once they do that, they go all over the body. And so one of the big questions is, how does it cross over this blood-brain barrier? Because the brain is a privileged site, as I mentioned. We don't fully understand how, especially cancers and cells from outside the body, develop the ability to cross over into the brain. That's one of the things that we're looking at to try to understand what they develop, what mutations they gain, what abilities they develop to cross over, but somehow they're crossing over that blood-brain barrier and break it down and are able to grow in an environment that they really shouldn't. But that's because they're abnormal malignant cells. But that's something that a lot of people are studying. And I think if we can figure out the mechanism of that, we will be doing, hopefully, we'll be really moving the field forward in what we're able to do to treat the patients. What type of cell? Meaning, so the cells that go to the brain, so say for a lung cancer, if this is, let me know if you're asking something else, but if you have a lung cancer, the normal lung cells develop a mutation somehow that transforms it into a malignant lung cell. So it divides inappropriately. All the cells in our body divide at some point, and then they lose the ability to divide as they mature. That's how we developed from a tiny little embryo until what we are now. As the cells divide, they usually are controlled by certain factors in the cell. If we lose that control, that's how cancer forms. The cancer is basically the loss of control for a cell to stop growing and mutating. And so if the cells grow out of control, they develop the ability to metastasize, they develop the ability to destroy the tissue because they start to bring the blood supply to them, and the rest of the organ doesn't get as much blood supply. And so the cells that actually go to the brain are the malignant form of whatever cell type it is that the cancer formed in. So whether that be lung cells, kidney cells, skin cells that have developed melanoma. So it's actually those cells that go to the brain. That's how we diagnose them, because we know what they look like. We can understand when we take the biopsy or the tissue out what it looks like, and that's how we know from which organ it came from. Let me know if that wasn't exactly what you were asking. And then Stephen, standard of care is TMZ. They have direct targets. Combos or old school. So for that question, that's for gliomas, and temozolomide is the standard of care. And then there are new drugs, what you alluded to, the vorasidenib, which are IDH. They target IDH mutations, which are present in some gliomas, not all of them. And so there's different indications for different uses of these drugs. You're right, the PCV combination was used for lower grade tumors, for lower grade specific types of gliomas. We don't typically use that anymore because we've seen that temozolomide has similar effects and they have less side effects. So often patients will be on temozolomide. So we do have a standard of care, and it's usually temozolomide with some caveats. But then we also have clinical trials that patients can be enrolled in to try some of actually the immunotherapy drugs that are being used for systemic care therapy. We're trialing in some of these primary brain tumors. Metastatic disease is actually not treated with temozolomide. So disease that comes from the body and goes to the brain doesn't actually respond to temozolomide. Only the tumors that grow from the brain. So the difference between the metastatic disease that we were talking about and things like primary brain tumors like gliomas, GBMs, is that those tumors are brain cells that go bad. So they're called glia or astrocytes in the brain. Those are normal brain cells, and they somehow develop the ability to grow out of control. And so it's the same process as cancers of the lung or the kidney or other organs. It's just a brain cell that's bad. And so those diseases are treated with temozolomide and vorasidenib and some of the newer drugs that are coming out for those cancers. It's a similar trying to attack whatever the mutation is or whatever is the vulnerable part of the tumors. Dr. Hines, you have a question about symptoms of spine tumors or spine mets.
Yeah, I mean, I think that they can manifest as a variety of ways. You can have pain, which can be localized to the spine. You can have pain that is significantly worse when you move or are weight bearing, what we say loading the spine. This can be indicative of, metastasis or tumors that have degenerated the bone and made it less stable. You can also have neurological symptoms such as uh, progressive gait imbalance, worsening balance, challenges in getting up out of chairs, going upstairs, this kind of unclear proximal vague leg weakness people can have. And then you can get kind of classic pinched nerve signs such as shooting pain or weakness or numbness. So these are all things in patients with a cancer history that would trigger us to want to do more of an evaluation and make sure that we're not missing spinal involvement of the disease.
I see. Okay. So the question about the cell type was specifically talking about the brain cells. So yeah, so that's specifically for the primary brain tumors. The when metastatic disease goes to the brain, it's interesting, it pushes the brain away. It doesn't infiltrate the brain typically. The the tumors that come from astrocytes infiltrate the brain. So that's also one of the differences. There's nothing in the pipeline for primary brain tumors. There are some things. The IDH mutant drugs that target IDH mutations are new, and there's many more being developed. And then I think one of the more exciting things coming down are the trials looking at the immunotherapies, and there's quite a few of them coming along. And then there's always clinical trials going on with, some of the other inhibitors and drugs. But as of now, there's nothing that has proven significant effect. We, we're hopeful that there will be more and more coming down. And I think some of these combinations of immunotherapies that we know are effective in systemic disease, with the right combination and the right way of opening the blood-brain barrier and targeting the cranial disease, I think, there may be some promise there, but it's a tough disease. The primary brain tumors is a tough disease, and there's many, many people studying it. And there are some things coming down that I think will be interesting and hopefully be able to target these tumors better. 2 separate radiation treatments in the same areas. Are there limits on how many times you can radiate? There are limits. There's a lot of caveats to that and specifics on how much radiation, where it is, what the size of the lesion is. But there's dose constraints where we don't like to go over certain doses. So our radiation oncology team really are the ones that would be looking at that. And I know Dr. Winyan, she is going to be giving one of these with a couple of our other neurosurgeons as well. And he can probably speak a little bit more to that. But there definitely are limits, but it depends on a lot of factors. And the more you radiate, the more at risk you are of treatment changes or treatment effect, which is something we always want to watch out for. So we have some trials here, and we can definitely plug you in with our team and talk about some of the details of them. But many of the different institutions have different trials depending on the disease and the mutations and what specifically each tumor needs, because it's very specific. These trials are very specific to the type of tumor, the mutations. And I know there's a lot out there. And so we definitely, can help you, get in touch with us, and we can definitely talk with you about that if that's something that you want to find out more about. Well, I hope that answered. Sean, are we able to?
So I'll put an email in the text box, tumor scheduling at jefferson.edu.
Perfect.
You can send that and we can forward it over to Dr. Robert and the rest of the team as needed.
Absolutely.
And you can use that email for any questions regarding the webinars. I want to thank everybody for logging in tonight. I know there was a recent change of the schedule. This was slated to be next week's webinar, and we had to push it up a week due to a unforeseen conflict. The webinar that Dr. Robert mentioned with Dr. Shi is now scheduled for next week. So if you do have some questions about radiosurgery or radio oncology, that would be a good one to check out. All of these will be posted, recorded and posted for future reference. And again, the email is tumorscheduling@jefferson.edu. I'll add it into the text box. Reach out if you have any questions. Thank you so much.
Thank you all.